The topics that we're going to treat today are the hemophilias A, B, and C. And I'm going to explain the different types of Willebrand disease as well. I would urge you to click on the like button, subscribe to this channel if you're interested, and I believe you're going to love it because most of these sessions are going to enlighten you on some of the things that probably you do, but you don't have the full picture of what it means. So we are going to spend this short minutes ahead of us to discuss two different diseases with similar symptoms. We have hemophilia and von Willebrand disease. Hemophilia is bleeding episodes as well as von Willebrand disease. However, their causes, their genetic aberrations that lead into both pathology are different. Now let's go into hemophilias. Hemophilia means bleeding, and they have grouped them into four so that we will know their names and the factors, the clotting factors that they are deficient, and which chromosomes they are found, and which arm of the chromosomes they are found in the philia. So these three are the inherited types of hemophilia. So there is acquired hemophilia, which is not genetically associated. So those are not the ones that we are going to discuss. So there could be a disease condition that could predispose you to have a bleeding episode mimicking hemophilia. In that case, for instance, if you have autoimmune conditions like systemic lupus erythematosus and other autoantibodies that attack and neutralize your factor VIII, and if possibly have any defect on your factor IX, that leads you into a bleeding episode. This one, the predisposure is not due to genetic aberration, so that is acquired. Here is an inherited one where a gene is defective, leading you into either low production or ineffective clotting factors. So the inherited types are A, B, C. All factors involved here are in the intrinsic pathway, the APTT pathway. That is why in most monitoring, it is the APTT ratio, that's APTR, that will be requested. So the hemophilia A goes with factor VIII, hemophilia B goes with factor IX, and hemophilia C goes with factor 11. So technically as a student, you would have think it should be 8, 9, 10, but remember factor 10 is in a common pathway. So jump it, go to 11, that is the hemophilia C. So you've got this hemophilia A, B, and C, and they match up to the 8, 9, and 11. And if you're able to grab this, the rest are easier. I pick it up as XX4. So it is an X here, an X here, and number 4. So the chromosomes that are involved in all hemophilias, apart from the acquired, are XX4. The first one is chromosome X for factor VIII. The second one is chromosome X for factor IX. And the last one is chromosome 4 for factor 11. And interestingly, there is no need to bother yourself about which arm. Once you talk about hemophilia, they are all on the long arm of their respective chromosomes. Very simple. Now, let me discuss something as far as the XX and this chromosome 4 autosomal recessive is involved. I'm going to explain three things. I'm going to explain allele, which we previously called allele, but the correct name is an allele. A-L-L-E-L-A. If you have two variants of the same gene, we say they are allele. So for instance, if we can have a black eye color, we can have a blue eye color. And if your parents are from different of these race that you acquire both of them, the two genes that depict an eye color are called alleles because they are two different genes, but their origin are the same. They are two different variant genes of the same gene type. That is what we mean an allele. They are variants. A tall and a short gene or variant are called alleles. Second, when we say recessive, a recessive means it needs twice of it for an expression. It means you need to inherit from both parents before that particular gene can be expressed phenotypically. When we say a dominant gene, it means that gene don't need to be paired before they can be expressed. It means each variant is able to express itself phenotypically independent. So, if you have a dominant gene or inherits from only one parent, that particular gene will express itself on you, whether both parents have it or not. That is what we mean. And an interesting thing about those that are X-linked or sex cell, Now, this chromosome X is double in females, whilst it is single in males. Therefore, if an aberrant gene is inherited by a female from one parent, it means there is a possibility that the other gene, X chromosome, on X chromosome, is not mutated. So it will express itself and produce the right factor VIII and factor IX in that female without having the disease expressed. If a male has that same gene aberrated or mutated, it means that there is no other choice. There is no option for factor VIII or factor IX expression or transcription for it to produce that protein. This means if a male inherits an X chromosome with factor VIII or factor IX aberration, hemophilia A and hemophilia B is going to be expressed fully. And therefore, males are predisposed to hemophilia A and B compared to females because they have an extra X chromosome that might not be aberrated. So looking at the third hemophilia type, you should be able to assume why it is less common. The reason is because it is autosomal recessive and you need 2 alleles of the gene from both parents before you can have the disease expressed. So your mom and your dad should have the chromosome 4 gene aberrated on the long arm that affects the factor 11 gene. Now, we will check on Willebrand disease. We will try and associate both of them on our subsequent slides, but for now, let's explain the different types within each disease and we can progress on that. For Willebrand disease, watch here the types that we have. The main types that we have are 3. Type 1, Type 2, Type 3. Type 2 has got 4 subdivisions. And there is another type of von Willebrand disease that is not as a result of the von Willebrand antigen or von Willebrand gene mutation. It is called pseudo, and pseudo means not original. Pseudo means it mimics, it looks as if, but it is not, which will be also talked about. So that is the general idea you should have. We have 3 main types, of which the second type has got 4 subtypes. Now, we will link them. For you to have a fair idea of the whole hemophilia that we are going to discuss, keep 3 things. 1, check if it is quantitative, that is how much von Willebrand antigen we have, or qualitative, the functional von Willebrand antigen that we have. And the last one here is ULVM. We say it is ultra large von Willebrand multimer. So we will check if it is quantity, amount, if it is quality, the functional, or if we have enough ultra large von Willebrand multimers. Good. So those are the ones that we are going to discuss now. The other aspect of the von Willebrand disease, you don't need to memorize because all the von Willebrand types are autosomal dominant, except the one that is not common. Just like we have here, except the one that is not common, which was recessive. The same way, the one that is not common will be a recessive one. Other than that, all types are autosomal dominant. And they are all on chromosome 12, the smaller arm. So, the first type of von Willebrand disease is quantity. It means not enough von Willebrand antigens are produced. So, the issue with von Willebrand disease has to do with von Willebrand antigen. Remember, von Willebrand antigen stabilizes factor VIII. Von Willebrand antigen binds to platelet. So, when we are discussing the von Willebrand disease and we associate it to bleeding, it is bleeding as a result of its interaction with platelets or bleeding due to its inability to stabilize factor VIII. Now, the first type, which is quantity, it is the only type that is talking about how much von Willebrand antigen, and it is solely about the quantity. And coming to the next type, which is the type 2, starting from the A. Remember this, when we talk about von Willebrand antigen amount or quantity that we have, we don't refer to ultra-large von Willebrand multimer. So the whole von Willebrand factors are assembled as ultra-large von Willebrand factor multimer. And there is an enzyme called Adams 13 that breaks them down into smaller ones if they are not needed or they are not being used within the peripheral blood. They can break your ultra-large von Willebrand multimers down and they will not be able to stabilize a clot. They will not be involved in clot formation. So in this case, if there is a blood test measuring your von Willebrand antigen within blood, it would give you a normal result. But when you do ristocetin platelet, because it is qualitatively defective, it will give you a low response, meaning it is qualitatively defect, but the amount is normal, but it is selectively deficient of ultra-large von Willebrand factor multimer. So in case we ask, is ultra-large von Willebrand factor multimer normal in this state? Don't think because it is qualitative defect, that one is normal. It is the von Willebrand factor antigen that would be normal. But the large multimer, which is required for platelet activation and clot formation, is rather deficient. So this is the case of the type 2A. It is qualitative, but the ultra-large von Willebrand multimer is selectively deficient due to probably Adam 13 hyperactivity. Now we go to the 2B. So I'm explaining the 2B here, and I have purposefully underlined those two. Let me get a blue one. Yes. So I've underlined this and I'll circle that. And I've underlined the pseudo von Willebrand disease, which is also qualitative. And if you look at the arrows, this is a hyperactivity. And as well, this is a hyperactivity. So they are both qualitative defect, hyperactivity, hyperactivity. These two are the differential diagnosis of each other because they give the same symptom of the disease, but their genesis differ. The type 2B is a gain of function mutation of the von Willebrand antigen receptor for platelets. It becomes highly sensitive to the binding of platelet glycoprotein 1b alpha, which has the IXV complex. So it binds to this particular glycoprotein. It's actually found on platelet surface. So the binding site of this von Willebrand antigen is sensitive to this particular glycoprotein, and therefore if von Willebrand antigen binds to this platelet, it activates platelet and causes a premature clot formation even if they are not needed. In this case, platelet will be consumed, von Willebrand antigens will be consumed, and of course clotting factors will be used up, and therefore resulting in deficiency of both the von Willebrand antigen, platelet, as well as clotting factors. And this leads to bleeding episodes, especially during surgical procedures. On the other side, which is pseudo means it is not directly the von Willebrand antigen, but it gives von Willebrand disease symptoms. The glycoprotein is now having the aberration. So there's a mutation in protein, platelet glycoprotein 1b alpha, the IXV complex, which is also a gain of function and therefore binds to the von Willebrand antigen, get them used up. And of course, anytime that von Willebrand antigen is being consumed, factor VIII will be unstable. Bleeding episodes will now be noticed in the patient. Now we move. So you've been able to explain the pseudo and that of the type 2B together. So anytime you see type 2B, remember pseudo. Both of them are gain of function. Both of them are going to consume von Willebrand antigen, and both of them will have the symptom of bleeding. So just like I've explained these two together, I'm going to combine the 2M and 2N. Always remember that they are all qualitative defects. And secondly, we know that once we are talking about von Willebrand disease, it means it is about the von Willebrand antigen. So in the type 2M, the von Willebrand antigen has a binding defect to platelets, because the ultra-large von Willebrand monomer here is normal, and the binding defect is why it is unable to initiate a clot that leads into bleeding. So it is ineffective, it's not able to stabilize a clot, it's not able to bind to platelet properly, and it is leading into a bleeding episode. And in the type 2N, the qualitative defect is unable to bind to factor VIII. It has a very low affinity to factor VIII, and therefore it leads into a bleeding tendencies. So these type 2M and 2N are all qualitative, but why they are defective is that one has a defective binding to platelets, the other has a defective binding to factor VIII. So technically, we have been able to establish the fact that the first type of Willebrand disease, which I'm going to select this for that. Yeah. So the first one is quantitative, and the second one has got 4 types. They are all qualitative. And the 4 types, it begins with this first 2A, which is qualitative. You know, it has a qualitative defective binding to platelets. However, we are also aware that the ultra-large Willebrand multimer is also low, and probably due to a hyperactivity of the Adams 13. So we've established that as well. And apart from that, the rest were treated in pairs. That made it so easier. So if you throw away the first one, quantitative, the second one that has low, which means that defective binding and also low ultra-large Willebrand multimer, the rest were treated in pairs. Now we treated the 2B and C though are all having a hyper-regulation of their binding sites. And we came into the 2M and 2N. They are all qualitative. One is not binding to platelets properly, the other is not binding to factor VIII properly. And in this, there is a normal ultra-large Willebrand multimer. So the next type that we are going to discuss here is the type 3, which is the last type. And this type 3 that I've just circled is the most severe type of Willebrand disease, and it is the most uncommon. When we say uncommon, that is why it is autosomal recessive, because you have to inherit the aberrated gene from both parents before that disease can be expressed on you. It is the lowest Willebrand antigen that you would ever record on a blood test. The reason is that you are not even going to have any Willebrand antigen when you do the test, and it is as a result of an Haemoph or a null Willebrand factor due to the genetic mutation. So the mutation is so severe that the aberrant gene or the Haemoph gene is not going to transcribe into any Willebrand antigen at all. And in this case, the factor VIII is severely going to be low because there is no Willebrand antigen to stabilize that. There is no Willebrand antigen to activate platelets, and the bleeding episode is so terrible. And don't forget, it is the autosomal recessive. So in the bleeding, in most of these diseases with bleeding episodes, the most severe ones are recessive, because you have to inherit both genes before you can express that extent of disease. And using the same idea in explaining fibrinogenemia. So the FGB gene, which is the fibrinogen gene, is found on chromosome 4. If there is an aberration of the FGB gene, which is on chromosome 4, it is either going to lead to afibrinogenemia, no production of fibrinogen, or hypofibrinogenemia, which is reduced amount of fibrinogen production. And this is the idea. In the production of fibrinogen polypeptide, there are 3 chains which are paired: the alpha chain, the beta chain, and the gamma chain. So the fibrinogen beta chain is the subunit that this aberration leads to its malfunctioning or malproduction. If it is recessive, just like I've explained, it means that you have to inherit from both parents before it can be expressed. In that case, if you are unlucky to receive both parents with aberrated gene, it is going to be very severe, and that severity is afibrinogenemia. And if only one is received from a parent, then the expression is going to be a hypofibrinogenemia, which means that if only one gene is received, it is going to express itself partially into a hypofibrinogenemia. Despite that we did not receive from both parents to be afibrinogenemia, you will still have a partial expression, which is hypofibrinogenemia. So this platelet activation structure, and it's also known as the platelet ultrastructure, it got different binding sites for thrombin, thrombosin A2, ADP. It binds to fibrinogen by its 2B, 3A alpha, and all that. It also has different binding sites for Willebrand factor. Willebrand factor also binds to collagen. So it's got different binding sites. And here I've written it down here. GP 1A and 2A binds to collagen, 1B IXV complex binds to Willebrand factor, and then 2B3A, the integrin, binds to fibrinogen. So that's it. So one thing you should know, there is a DDVAP, which is 1-diamino-8-D-arginine vasopressin called desmopressin. The desmopressin is a synthetic analog of the hormone vasopressin. And we know vasopressin is an antidiuretic hormone that interacts with the renal tubules for water reabsorption. And this desmopressin, if it engages with the vascular endothelium, it is able to trigger the release of von Willebrand factor, that's ultra-large von Willebrand factor, from the Weber-Pallade bodies, like I mentioned in my previous video. So if this desmopressin can trigger a release, then any of those types of von Willebrand disease that is due to von Willebrand antigen deficiency, desmopressin can solve it. Just that it's not all cases that it can solve. So just like I've written here, it interacts with vascular endothelium. And remember ristocetin. So ristocetin is an antibiotic, a cofactor required for von Willebrand factor antigen to bind to platelet. So if you want the von Willebrand factor to bind to platelet, you use this ristocetin as an agonist to trigger that activity. It was previously an antibiotic, which is now used in the lab for this particular purpose. It represents physiologic shear stress, a shear stress, as if platelet is passed under a pressure during a tissue injury. And that is how the ristocetin put pressure on von Willebrand factor or antigens, and it leads into binding to platelets. And this is where clotting is initiated. I have written a list of the known products, and these are coagulopathy medications that are given for hemophilias and von Willebrand diseases, and any of the factor deficiencies can be engaged, and there are also reversals that are given during treatment. So Esperoct is for factor 8, and this is a clue. Wherever you hear oct, is 8. So Esperoct, Elocta, Atuvoct, all of them have to do with factor 8. And then the ones that you have to just grab without any link is Obivor and Advate. So Esperoct and Elocta are all factor 8 replacements. So they are analogs made for replacement of people who have factor 8 deficiency, and it's for hemophilia A. It is preferred for 12 years and above, whilst the Elocta is for all ages. So if there is a child below 12 years which has factor 8 deficiency, it's preferable to choose Elocta and not Esperoct. But Obivor here is for only acquired hemophilia. And I've explained before that acquired hemophilia is not genetically caused. It is due to autoimmune diseases that has destroyed or dissolved away your factor 8 that you want to replace. Here it is a recombinant. So almost all of these are all recombinant. Recombinant means it is a synthetic analog that has the structural function just like the natural one, but it is synthetically produced. And most of those analog are prepared in such a way that they will stay in blood for longer. That means it has an extended half-life. So most of them have extended half-life. And if you see it is standard half-life, it means that it is not extended in any way. And I've told you this is acquired hemophilia, not genetic. So if it says that it is standard half-life, there is no news. But those that are genetically related, it means that they have to extend the stability of the medication in blood to extend it higher. And this is octocoque alpha for Advate. There is another slide here, and which is for factor 8 and von Willebrand factor as well. This is Willate. So it has a ratio of factor 8 and von Willebrand factor all present within here. It's called Willate, and it is for von Willebrand disease and hemophilia. And it's also used as prophylaxis for surgical procedures. And if you need more of these explanations, you can get them from the British Pharmacopoeia and American Pharmacopoeia. You get much information about that. So we have Vivendi as well, which is also for von Willebrand disease. And this is recombinant human von Willebrand factor. It means it is recombinant, it is synthetic analog, and it is human. It means it was structured exactly as how the human von Willebrand factor is. That is what it actually means. The generic name is Vonikov alpha, and it is standard half-life. Means it wasn't extended, it was just made in the structural appearance of the human type of von Willebrand factor. So Vivendi and Willate are for von Willebrand factor replacement. Now we have the factor 9s. This is Ardevion, Aprolex, and Recombinant. So Ardevion, Aprolex, Recombinant. So all of them are for factor 9 replacement. And are they extended half-life? Yes. So once you see extended half-life, automatically you should know they are recombinant. So R human albumin. So they are recombinant human albumin. These are protein IgG. So it is fused with protein IgG so that it can be incorporated into the human system. And this is fused with glycopolyethylene glycol. So that is how it is. Its stability has been made. So they are extended half-life. And how extended are they? This one is fused with human albumin so that it can be stable for long. This one is fused with protein IgG1 so that it can be stable for long. This one is fused with glycopolyethylene glycol so that it can stay for long. So that is for them. And don't forget you have antithrombin. And this antithrombin is for antithrombin 3 replacement. And I believe you know that for the thrombophilias. And this is standard half-life. It means that it must have been extracted from the human plasma. Once you see it is standard half-life, it is not recombinant. So this is IV pooled human plasma replaces. So it means that it was actually extracted from pooled human plasma. It's not recombinant. It is natural, and it's mostly a lyophilized one, a powdered type. Now we go to another slide, which is this slide giving us more. So this is also antithrombin as well. So that first one was extracted from human plasma, but this is atrin, and this looks recombinant. So the antithrombin 3 can be replaced with either the thrombate, which is the AT3 naturally extracted, or the atrin, which is a recombinant, and it has the standard half-life. Anyway, it is the first recombinant one that has standard half-life, and it is made from goat. Interesting. So this is Novo7. Nobody should even tell you that Novo7 is for factor 7 replacement. Fabriga is for factor 1 replacement. And I nearly got confused. I was always thinking that those that start with FAB are all for fibrinogen, but interestingly, only Fabriga, that is for factor 1 replacement, and it is human fibrinogen. This fever, this has nothing to do with fibrinogen. Yes, so it is anti-inhibitor coagulant complex. So anti-inhibitor coagulant complex, and it is to control bleed in inhibitor developed hemophilia A, B, and acquired hemophilia. So if a patient has developed an inhibitor against hemophilia, they choose FIBA instead of the up there, the listed Elocta, Esperoct, Obivol, those that were stated up there previously, like I told you about. So this is especially for inhibitor, and there's some few more. So for instance, fibrogamin, it looks as if it is fibrinogen replacement, but it is for factor 8. So apart from Fabriga, the FIBA is for inhibitor developed hemophilias, and then fibrogamin is actually for factor 8 replacement, and it is human plasma derived. So it's not the recombinant, and it is standard half-life, not extended. Now, there could be instances where you take anticoagulant for treatment or prophylaxis purposes, especially during surgeries. There should be reversals that should stop that particular anticoagulant control that you have been given. So for instance, this is Andexia, and it is commonly called the andexinate alpha. What does it contain, or what does it stop? Now, if you take apixaban, rivaroxaban, which are all anti-10. These two are anti-10. You have low molecular weight heparin, apixaban, rivaroxaban, edoxaban. Those are all anti-10. If you take them, but these two are mentioned for this matter, and they stop all your anti-10, you have to take andexinate alpha that contains recombinant anti-10 to replace all those that apixaban and rivaroxaban has inhibited them. So it's for IV replacement of the factor 10 that has been inhibited by the DOACs, and that is what happened there for andexinate alpha, and it is mostly effective for apixaban and rivaroxaban. Then we go to Praxband. So for Praxband, the opposite of the anti-10, or the other side of all the anti-10, is the dabigatran, because it is the only anti-2 that we have. So it binds to the dabigatran and inactivates it. So Praxband is for dabigatran. You can't use Praxband for low molecular weight, apixaban, rivaroxaban, because they are all anti-10, whilst only dabigatran is anti-2. So this is for IV, and it's monoclonal antibody fragments, and its generic name is here. It is idarucizumab. Oh, lovely. Anyway, don't bite your tongue. We have Octaplex. Octaplex is common. You know it as a prothrombin complex concentrate, which contains the prothrombin factors. I've mentioned it previously, that factor 2, factor 7, 9, and 10 are prothrombin factors. So this factor 2, factor 7, and 9, and 10. So, and also protein S and protein C are also part of the prothrombin group of factors. So if you take any of these, you can reverse with Octaplex, and it is human prothrombin complex concentrate. Don't forget it, and it's a standard dose. So that is what Octaplex does. Thank you very much for your time, and I've got much of this for you. Like, share, and subscribe.